Well, take it easy, Count.
I'm ready whenever you are.
Just waiting to see if the live stream is rolling.
Okay.
Okay, we are good at this time. Sergeants, please start your recordings.
PC recording has started.
Thank you. Cloud has begun. Good morning and welcome to today's remote New York City Council hearing for the preliminary budget for fiscal year 2023 and the Committee on Hospitals. At this time, would all panelists please turn on their videos for verification purposes? And to minimize disruptions upon speaking, please place all electronic devices to vibrate or silent mode. If you'd like to submit testimony, please send via email to testimony@council.nyc.gov. Again, that is testimony@council.nyc.gov. Operation Chair Narcisse, we are ready to begin.
Good morning. Let's begin. Good morning, everyone. I'm Council Member Mercedes Narcisse, Chair of Committee on Hospitals. I'm very excited to be co-chairing my first budget hearing of this committee with the Chair of the Subcommittee on COVID Recovery and Resiliency, Council Member Francisco Moya. During today's hearing, we will discuss the fiscal 2023 preliminary budget for New York City Health and Hospitals. I would like to thank everyone that has joined us today, and I acknowledge my fellow members of the committee, Council Member Moya, Francisco Moya, and Council Member Brooke Powers. I want to start by thanking every single employee of health and hospitals who continue to risk their lives every day to provide care for New Yorkers. I've been a nurse for over decades. I know firsthand how much dedication, love, and commitment that healthcare providers provide to their patients. The last 2 years has been particularly difficult, and I want to say that we applaud you, appreciate you, and hope to hear about how can we continue to support you. The pandemic took a huge toll on the healthcare workers and exacerbated a long-standing issues of staffing ratios. The city needs to start recruiting students at young age and incentivize them to join the healthcare system. The state proposed budget includes several staffing initiatives, but the city can go over even further. H&H, Department of Education, and CUNY should collaborate to streamline training programs and ensure that once students are out of school, the salaries are comparable in public hospitals and within private hospitals. While the number of cases of COVID-19 in New York City continue to decline, that does not mean the pandemic is over. We must stay vigilant and prepared for further surges. The city was caught off guard by the onslaught of cases due to the Omicron variant this winter. But we had a similar increase in cases in the winter of 2020 due to holiday gatherings. And remember, the summer is coming. H&H and the city must do better to prepare to recognize these trends to be ready for future spikes. H&H must be prepared to stand up an increased number of testing sites in the moment's notice. As we adapt to live within the pandemic, we must return our attention to primary care and preventive medicine. COVID took too many lives due to health disparities and chronic condition that could be managed or prevented. And due to COVID, so many people have engaged in primary and preventive care like they did pre-COVID. We need to work towards making healthcare affordable and easier to navigate. There needs to be an affordable primary care clinic within walking distance of every New York's house, which is H&H, and NYCHA houses. H&H Garden clinics are a great foundation that the city needs to continue to expand. Primary care must incorporate both physical health and mental health. We look forward to hearing more from the administration today on how we can work together to ensure primary and preventive care, how preventive care a priority moving forward. I want to thank the administration who are here today, and I look forward to your testimony. I also want to thank our council committee staff, Senior Legislative Counsel Habani Hawuja, Senior Policy Analyst M. Balkan, and Financial Analyst Lauren Hunt for making this hearing possible. Thank you. I also want to thank my Chief of Staff, Syed Joseph, and my Deputy Chief of Staff, Frank Shea. Thank you, and I look forward to a great discussion. I will now turn to it over the council member, Moya, for opening statement. Thank you.
Thank you so much, Chair Narcisse. Good morning, everyone. I'm Councilmember Francisco Moya, Chair of the Subcommittee on COVID Recovery and Resiliency. It's great to be here co-chairing this budget hearing with our Chair of the Hospitals Committee, Councilmember Narcisse. During today's hearing, we will review New York City's Health and Hospitals fiscal 2023 operating budget. And I would like to thank everyone that has joined us here today. Look, it's impossible to forget the first months of 2020, the incessant sirens, 24/7, the long lines at Elmhurst Hospital. As many of you know, Elmhurst Hospital was the epicenter of the epicenter. And for me, it was much more than just one hospital in the city. It was more personal for me. I was born at Elmhurst Hospital. I worked at Elmhurst Hospital, and I've represented Elmhurst Hospital for over a decade. This is a hospital that works hard to serve my district, the very communities that were hardest hit by this pandemic. So making sure that they have the support that they need was paramount. I remember clearly those first few days and months, whether it was being on calls to ensure that we could serve our communities and personally securing and dropping off over 120,000 PPEs for the staff because supplies were limited for our frontline workers at the height of the pandemic. Elmhurst's capacity was pushed to its limit, but the hard workers did everything that they could to continue to provide support for Queens every single day. Our heroes at Elmhurst Hospital have been a beacon of light, a symbol of hope, and an example of leadership and resiliency, which this city needs to applaud. Which is why we need to ensure that the city and H&H take lessons learned from this catastrophe to be better prepared for the future. H&H and the test and trace have played a vital role in fighting the COVID-19 pandemic, and we must ensure that the resources are in place for this support to continue in the next fiscal year. The city has been able to stand up and make sure that their pandemic responses should be within days, not weeks or months. PPE supplies must always be available. We cannot wait for another surge or another contagious disease in order for us to react. The restrictions may be lifting, but this pandemic isn't over, and it may not be the only pandemic that we face in our lifetime. We must be prepared, and the funding must be available to ensure this preparedness. So I want to take this opportunity to thank the administration for being present today, and I look forward to this discussion. But I also want to take this opportunity to thank, again, the great council staff, because without them, these hearings don't run at all. They've been truly the backbone of what makes this council great. So thank you to our senior counsel, Sarah Liss, Habani, as well as our policy analyst, M. Barkin, the financial analyst, Lauren Hunt, for making this hearing possible. And a big shout out to my chief of staff, Megan Taddeo, who dropped off her baby girl today for the first time at daycare. So I know that she's busy this morning, but we're thinking of you, Megan. Thank you so much. And with that, I'd like to turn it over to our committee counsel to go over some of the procedural matters. Thank you.
Thank you, Chair. I'd like to also recognize that we've been joined by Councilmember Rivera. My name is Herbani Ahuja, and I'll be moderating today's hearing. Before we begin, I just want to remind everyone that you will be on mute until you are recognized to speak, at which point you will be unmuted by the host. If you mute yourself after you've been unmuted, you will have to be unmuted again by the host, so please just be aware of that. And there may be a delay in muting and unmuting, so we thank you in advance for your patience. The order of today's hearing testimony will be as follows. The first panel will be representatives from New York City Health and Hospitals, followed by council member questions, and then the public will testify. During the hearing, if council members would like to ask questions, please use the Zoom raise hand function and you will be called on in the order in which you've raised your hands. We'll be limiting council member questions to 5 minutes, including responses. I will now call on each witnesses to testify, including those available for Q&A. Testimony will be provided by Dr. Mitchell Katz, New York City Health and Hospitals President and CEO. Additionally, the following representatives will be available for answering questions. Dr. Patsy Yang, New York City H&H Senior VP for Correctional Health Services, and John Ulberg, New York City Health and Hospitals Senior VP and Chief Financial Officer. I will administer the oath and call on each panelist individually to respond. Please raise your right hands. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee and to respond honestly to council member questions? Dr. Katz?
Yes.
Thank you. Dr. Yang?
Sorry, yes.
Thank you. And John Ulberg?
Yes.
Thank you so much. Dr. Katz, you may begin your testimony when you're ready.
Thank you so much, and good morning, Chair Narcisse. I want to say how great I think it is that the hospital committee is now led by a nurse, because we know that nurses are the very heart of hospitals. So I think that's incredibly wonderful. And also, good morning to Chair Moya. I want to acknowledge that during those horrible days, that Chair Moya was at Elmhurst with us, that he was there to cheer us on, to ask us whether we needed any more help, as was, I know, at the hearing, a council member, Rivera, also constantly calling me, what can we do? How can we help? I mean, the city council was just amazing at supporting us, asking us how to help. And, you know, we will always be eternally grateful. Those were horrible moments to have lived through, but we're glad to be on the other side of this. I'm here with my excellent CFO, John Ulberg, and Dr. Patsy Yang, who does a great job running correctional health, and they'll answer specific questions about their area. Health and hospitals, as the chair has explained, has been a critical part of New York City. I'm very proud to be entering my 5th year as the CEO, and the single thing that makes me proudest is how many of our staff came to health and hospitals with their parents as children. That would actually include me. My family all got our care at Coney Island Hospital. But many people doctors, nurses, all support staff actually used health and hospitals and are happy to come back now and give back to their system. When COVID arrived, it was extremely difficult, but we lived through it. In the last year, we've spent most of our time recovering from that horrible March of 2020 and dealing with smaller outbreaks. In our testing area, our team, and this is not an exaggeration, 10 million COVID tests. 10 million COVID tests we did. People in New York City who had never used the public sector learned that if you want to get a test result in the next 24 hours, you go to a health and hospital site. Our test and trace people called those people who tested positive, helped connect them to resources. We were the only city to have a hotel because we recognized that there were many people who wanted to isolate, but they couldn't isolate. They were in a multi-generational family in a 2-room apartment. How could they isolate? So we had a hotel. We walked people's dogs. We brought people their medications. We brought food of every ethnic group. We did whatever was necessary to allow people to be able to safely isolate. We did 1.7 million vaccines, and we didn't just vaccinate for our patients, we vaccinated New Yorkers across the city. And I'm very proud that when we looked at the data compared to the private hospitals, we vaccinated many more people of color. And you'll remember that early on, one of the concerns was that the vaccinations were not being equitably distributed across our city, health and hospitals, because of who we serve, because people trust us from the Black and brown communities, from the immigrant communities, because they know they'll never be turned away. They'll never be forced to pay a bill they cannot afford. For those reasons, we did a much larger percentage of people of color. We're working to recover. We have 3 new COVID centers of excellence. We were very proud that Chair Narcisse came to our recent opening in Brooklyn. We're going to be there for people who have long COVID. We recognize it's a puzzling and upsetting syndrome. We're there to take care of people, as we always are. I don't want you to think that we've forgotten about our other work while we're taking care of people with COVID. We've now enrolled 90% of uninsured patients to our health insurance or NYC Care, up from 70%, so that people always have a way of paying for their care. Our Metro Plus health plan is the highest ranked in terms of quality Medicaid plan in New York. We grew to over 400,000 unique primary care patients. We earned substantial Medicare savings. We established a maternal home for moms having children that provides all the wraparound services they need. We've expanded our lifestyle medicine program following the model of our mayor, who recognizes that food can be medicine, that a healthy lifestyle is as important as and sometimes more important than modern medical treatments, to exercise, to meditate, to eat the right things. And we want to be a part of that. We've added diabetes services for Staten Island. We have the only gender affirming practice that I'm aware of in any public system. We passed 100 gender affirming surgeries at Metropolitan, which we were very proud of. And we've opened up a new Pride Center for LGBTQ people at Jacoby. We're continue to be a leader across the nation in correctional health. As the chair referred to, we recognize that our staff have gone through hell. I want to use the vernacular because that's how I feel it was. And so we are, using Helping Healers Heal to try to make our staff feel better, to overcome the trauma of having lost so many, including their own colleagues. We had nurses taking care of nurses that they worked with. We had doctors taking care of doctors that they worked with. We had nurses who were holding the hands of patients as they died because those patients had no family that could come because of the pandemic. Those are traumas. Our staff, as the chair explained, they were brave, they were great, but they're hurting, and they're still hurting. And we're doing our best to try to help heal those wounds. This is a budget presentation as well. We are closing the first half of fiscal year 22 with a $141 million net negative variance, but it reflects only that we haven't yet been paid all of our FEMA dollars. And I want to especially acknowledge how we've gotten great support from Leader Chuck Schumer, from our Congressman Richie Torres. The two of them have been really stalwarts at getting FEMA to pay, and we certainly expect that they will pay. And with that, we have no hole The hole is just a cash flow problem. Going forward, we had 42 days cash on hand, which is historically the most we've had. I'm very proud. When I came, there was a $2 billion hole. There was talk of what's going to have to be closed. How will we ever, keep all of the things running? And it turns out we've retired that hole. We no longer have a deficit, and we have done that without billing our patients. We have done it by learning how to bill our insurance appropriately, how to put the right diagnostic codes, how to get competitive rates from insurance plans, how to appeal when we don't get the correct amount, how to enroll people who are eligible, and all of those things together eliminated the deficit. And going forward, we are running even, and we hope to be able to generate enough dollars to, with the city, address the tremendous infrastructure problems of health and hospitals. Because while I have the absolute best people in the universe, and I could not ask for better nurses, doctors, respiratory therapists, psychologists, support people, many of my buildings need work. Elevators, aeration systems, they're not sexy, but you can't run a hospital if the elevators don't work. So we have to be able to generate enough dollars to be able to have a sufficient amount of money for infrastructure. We are grateful at the state level. Senate Health Chief Gustavo Rivera and Assembly Health Chair Dick Gottfried have been great at helping us to get our dollars. And again, I want to close by saying there's no better job that I can imagine than being the head of health and hospitals. I get all my care at health and hospitals. My parents who are in their 90s, my children who are teenagers, my husband, we all get our care at health and hospitals. I greatly believe in the system. I take care of patients at Gouverneur. This is my system, the system I grew up with. I love the people in it, and I'm 100% committed to its success. Thank you so much.
Thank you so much for your testimony. I'm going to turn it to the chairs for questions. Chair Narcisse.
Good morning again. Thank you. Thank you, Dr. Katz. And I appreciate working with you. And one of the joke I have to share before I get to the question, someone told me I'm the only medical professional excited to come to a hearing about health and hospitals or anything has to do with health. And I was like, what? You said it's only you, but I see how others like my council member Moya is excited too. I'm talking about it, and he's not a doctor. He's not a nurse, so that's very hopeful. And by the way, Elmhurst Hospital gave me my first chance as a nurse. Did not ask me experience. They realized I was excited. I was starving to serve, and that's where I work. I ended up in the emergency room for many years. So it is a pleasure for me to be here. And Dr. Katz and all the team, thank you. Gotham clinics play a major role in providing primary care health directly in the communities. How many Gotham clinics are currently supported by H&H? Does H&H either have a Gotham clinic, hospital, or partnering with FQHCs or CBOs in each community district? If not, how many districts are without? Second, does H&H regularly assess which New York City neighborhoods lack sufficient access to healthcare services? If so, which council district are in the greatest need? I hope you can remember all. So I'll let you answer those before I go further. Thank you.
Okay, well, let's start on, because I always feel that we should start on mission. I know in the private sector, when they're figuring out what clinics to locate, they always look to figure out, I had a friend who did this kind of work, where are the most Cadillac insured patients? And that's where they want to put their clinic, wherever there are the patients who have the highest rate of insurance. Here at Health and Hospitals, we do the opposite. We look at the maps and we say, where are the largest number of uninsured people? And those 3 clinics that we opened up, the centers of excellence that we opened up, are all in areas where we were able to show that the need was great and the supply was small. We do partner with the other FQHCs. We don't want to ever be competing. Our goal is never to compete. Our goal is to fill the specific needs of our patients. So depending upon, I have to say our clinics were not, where they are is historic. And of course, council districts change over time. So our geography doesn't always fit the same, ideal of the map. And once they are in their place, they're not mobile. I can't move them from one spot to the other, although neighborhoods change. And sometimes I wish I could tug a physical building a little bit more to the left or to the right, depending upon, where the largest concentration of uninsured people is. I feel we do have, with the FQHCs, we do have areas that are covered well. I feel there are other areas that are not so well covered. And as you and I have discussed, Chair, you live and represent in one of those areas. The area of Canarsie does not currently have a Health and Hospital of Gotham site. I know the area well. I used to fly kites in Marine Park, and my grandparents lived in that area. We're going to look at whether or not there is a way to place a clinic there. And I totally agree with your mission statement. You want primary care to be very close to where people live and work. Not so with hospitals, because hospitals have to have enough volume to be able to offer incredibly specialized services. So you can't possibly have a pediatric neuro-ophthalmologist at every hospital, but there are kids who are going to need that kind of service. So you always want to, when it comes to hospital services, you want to make sure that there's enough volume to support all of the specialties you need. But primary care, you should be able to walk or take a bus. It should be very close to your neighborhood. And I will get over the course. I don't want to miscount and then feel that one of my clinics was not numbered. So before the end of the hearing, I'll get you the exact correct number.
Thank you. I know the district, I understand what you just said. You cannot move the clinics based on, where the demographic change, but some areas remain the same for many decades and nothing had been done for that one. So can H&H develop a strategic plan to expand services into areas with limited access to healthcare? And how much would such an expansion cost?
Well, I think the first step, Chair, will be let's together create that strategic plan. Let's look at all of the places we currently have clinics. We do have 70 sites where we deliver outpatient care. Now, those are not all Gotham clinics. Some of them are small, say a clinic in a NYCHA facility. But we do have 70 sites where we provide care. Let's together map it out. Now that we're through the worst part of the COVID pandemic, we can devote much more time to looking at those areas. We'll get out the maps. We'll look at where we're located, where the other FQHCs are located, where are the largest groups of people who don't have insurance, and together let's plan those clinics. In general, we can, if there is sufficient volume, we can open up additional clinics. Often we need a little bit of help with the initial startups because of the initial capital. But at a certain point, the revenue from providing services should provide most of the cost of those clinics. So it's not as if we're providing services that don't have a revenue source. And with the work at the state to try to make Medicaid a more competitive rate. We don't have to make money. We just would like not to for the city to have to subsidize Medicaid. We'd like Medicaid should provide the cost of the services. So together, I think we can figure out how to do more sites with you.
Okay. How long will it take to put a site together? Can you do it in a short term, especially in the area have the greatest needs? And how is mental health screenings and treatment included in the primary care? And how can physical health and mental health be better incorporated?
Sure. And this will come to no one's surprise on the council. The largest challenge in citing something is the physical structure. It's identifying in this crowded urban metropolis we live in a site. If you said to me, Mitch, here's a site that will work, we could open it up in 3 to 4 months. But the find a site, renovate a site. So we were able to renovate the Center of Excellence that you were in within 6 months. And that's because under the COVID exclusions, we were able to use a method of building that is normally not allowed, which is design construction. So instead of in the usual project, first you design it and then you construct it. In design construct, the designers and the construction firms work together. And so you do both things simultaneously. And we showed we could renovate a site in 6 months. And during that 6 months, we would staff up and open it. So the challenge is the site. It's identifying it, it's having the community feel that it's the right place, and that when we're able to do that, we can do very well. I appreciate the question about how to best cite mental health. Mental health is health. There is no, separation. We're humans. Our mental health and our physical health cannot be separated. You cannot say where one happens and where the other one happens. We're one organism. You cannot separate them. And yet our healthcare system, and including our insurance system, have often seen them as completely different things. Oh, over here is your physical doctor. Over here, you have to see a mental health provider, with bias against mental health, with fewer visits, more restrictions. No, we don't do that. And all of that is wrong. Many of the patients I see have a mix of physical and mental health challenges. And my job as a primary care physician is to heal them both. I think that ultimately you can have your primary care doctors handling mental health issues so long as you give them sufficient backup, so that when there is somebody for whom there's a difficult mental health issue, you can get consultation with a psychiatrist. You can, I'm able at my site and all our sites to arrange for people to see a mental health professional. We want to do more. There is a workforce issue right now where there are simply not enough mental health clinicians, especially psychiatrists. That's a product of the pandemic, and we hope in recovery we will be able to have more psychiatrists, psychologists, psychiatric social workers, psychiatric nurse practitioners, because we definitely have the demand.
Thank you, Dr. Katz. Before I go to the next question, I want to acknowledge my colleagues, CM Rivera, Gutierrez, and CM Barron. Thank you. And I guess you're excited to be here to talk about hospitals, because hospitals is important in our community. The fiscal, maternal health has been a big problem. We know that in our community. We lose for every 8 Black women that die, is to our counterpart is only 1. So I'm not saying 1 is not good for them, but then again, that's mean we as a medical team not doing our job. The fiscal 2023 preliminary budget includes $3 million for maternal medical home and OB simulations for fiscal 2022. And the out years, can you provide a breakdown of the 3 million, how much of the funding will go to personal training equipment? Who will qualify for the maternal medical home? Will hospitals outside of H&H qualify? How many total midwives does H&H have on staff? Can a number by facility be provided? How many total doulas does H&H have on staff? Can a number by facility be provided? For facilities that don't have a midwife or doula on staff, does H&H have contracts with any COBs to provide services if one requested?
That's great. We'll provide all of that information. And just to emphasize with you, as you know, as a nurse, midwives and doulas, we believe, are essential to providing a higher standard of care. We also like the maternal home because it gives us the opportunity to provide the kinds of wraparound services that pregnant women and new parents need. And so that will be an area where we hope very much to expand. I agree with you that there's a problem here, and it's been a problem for a long period of time, and we have to find a better solution than we have found thus far.
Thank you so much, Dr. Katz. And we're going to have a short hearing because very soon I will get a question from my colleagues as well. H&H transformation, because I know you have been doing a lot of work and I appreciate all the work you've been doing. Dr. Katz, thank you for your work because your commitment, like we said, is only hospitals folks that excited to talk about the change in healthcare more than anyone. And that's the way it's supposed to be anyway, because if we're not excited, who's going to be excited for us? Can the council be provided the actual for fiscal 2020 and fiscal 2021 for the following: third-party revenue, other revenue, revenue strategic initiatives expenses, and expense strategic initiatives? One of H&H expense savings strategic initiative is restructuring and personnel. How has the increased need of staff impacted this strategic initiative? The financial plan provided to council finance by OMB has the restructuring and personnel initiative saving of $235 million in fiscal 2024. How does H&H plan to achieve this goal? How does H&H evaluate each facility for waste in expenses? Their checks and balance in place to ensure that purchase of supplies and equipment match each facility's need. Their checks and balance to ensure that returns of excess supplies or mistaken orders are returned for refund. What other areas could H&H explore with each facility to determine where more savings can be found?
Well, thank you, Chair. The biggest opportunity, which we have just been scratching the surface, is operating as a system. So when I came to Health and Hospitals, I learned that often each hospital had its own contract to purchase a service. And of course, you don't get the best price when you're doing it for just a hospital compared to a whole system. You get the best price when you put together the volume. It has other advantages. I'll never forget, it was a typical Health and Hospital learning moment when at the peak of the pandemic, I was looking at a new form of ventilator and I needed to find out about the bamboo bag. You'll remember that from your practice, Chair, that you use to put air into someone's lungs. Yeah. So I called to a hospital to find out which one we used in order to make the ventilator work. And then I discovered that I thought, well, I better check. So I called the second hospital and found out they used a different one. And I called the third hospital and I found out they used a different one. And no one had any particular reason for why they used a different one. It's just that was how it was at that hospital. So a lot of the savings comes from buying in bulk, getting better prices, not issuing. Each one of those contracts takes tremendous administrative work. in a city bureaucracy, you have to certify each of those contracts. We're certifying 11 contracts to buy different Ambu bags when we could buy one set of Ambu bags and get a better price. So that's where, I think this is true for drugs. I think it's true for equipment. We chose a new vendor for our radiology equipment, and that resulted in huge savings without any losses, right? I don't want to cut services. I'm not interested in cutting services. I'm interested in figuring out how do you provide more services for the amount of money that you have. And we will, with you, keep working on that.
Thank you so much. We have more questions, but right now I am gonna pass it to Harbani Ahuja. Thank you.
Thank you, Chair. Thank you. I'm going to turn it to Chair Moya for any questions before we turn to council member questions.
Thank you, Chair Narcisse. Good to see you, Dr. Katz. Always good to have you here. I'm going to be brief with some of the questions. I want to go through them as quick as I can. But just talking about the long haul COVID for a second, H&H launched the COVID-19 Centers for Excellence, to provide services for people experiencing long haul COVID. Can you just tell us what is the most recent update on the Centers for Excellence, and how many centers will there be there in total?
Thank you, Chair. So there are 3 centers of excellence where we're able to, besides the clinical staff, have some of the additional respiratory, especially equipment for things like pulmonary function tests, which matter quite a lot after COVID. But all of our hospitals are seeing people who have long haul COVID. And as you know, it's a very variable from, people who experience it for just a short time after COVID to people who have it months later, from people who have very minor problems post-COVID to people who are having really serious fatigue. So we would never try to send everybody to the centers of excellence. We want people to go where they're most comfortable, but those 3 centers do have the extra equipment that is helpful in evaluating people. And so if you're at a center where that equipment doesn't exist and you need for your patients to get pulmonary function tests, we can refer that patient to one of those 3 centers.
Can you just tell, maybe some folks don't know, but can you just tell them where they're located?
So we have, I think, why don't we get the exact addresses so that I can say them correctly. I don't want to misstate exactly where they are. We have them in.
That's fine. It was just more for the public and some of our members.
Yeah, I will, before the hearing, get the exact sites and read the addresses.
Thank you. And going to test and trace, at the beginning of March, it was announced that H&H would end the contract tracing program. What is the time limit for the dissolution of the contract for the contact tracing program? Sorry.
So it's going to end about 6 weeks from now. We're currently working. So we gave an 8-week notice, of which there's about 6 weeks left. We want to use this period of time to develop resources so that people can get treatment that they need, which is the most important aspect. Part of what changed is Omicron is so contagious, and the period of time between which somebody gets exposed and gets sick is so short that the former kind of contact tracing, which worked well for the original COVID, just doesn't work very well. If you think, and almost all of us had those interviews, in the beginning, we would say, who have you been with for at least 10 minutes in a room without a mask, closer to within 3 feet? Well, with Omicron, it doesn't really matter. we're getting exposed by being in an elevator for 30 seconds with somebody else. So the idea of trying to run through who are your contacts and calling those contacts just isn't anymore a productive thing. What is productive is to get people the antiviral drugs and the monoclonal antibodies. And so anybody can call 212 COVID-19, and we will connect them by phone or by video to an emergency room doctor or nurse practitioner or physician assistant. And they will be evaluated, and they'll, at the end of that session, if appropriate, and they are supportive, a prescription will be sent or an infusion appointment set up so that they can get treated. Because the biggest thing that we've changed now is that besides vaccination, which is what's going to prevent infection, but if someone already has infection, the big difference between now and a year ago is we have great treatment. And we want to make sure that everybody gets that great treatment. And those virtual visits are provided regardless of insurance status, whether you're one of our patients or not. So most of the work in the next 6 weeks is about informing people about that treatment, how to get it, and make sure that the system works smoothly.
Time expired.
So I'm going to go. I'm going to go into treatments in a minute, but how many of the individuals employed by the contact tracing will be incorporated into the existing or any new H&H programs?
So we incorporated 250 who are working now as community health workers, connecting people from clinics into the community. And we were very lucky because the test and trace were people from the community with great language capability. And so it's worked very well. There are about 860 people who we're not continuing, who are in this role. We're very anxious to hire as many of them as possible into other roles at health and hospitals, because frankly, this has been a difficult time to hire people. We have a number of vacancies. These are all people who have proven themselves. There is some of them who wish only to do virtual work. So about half of the contact tracing people worked only virtually. And we don't have that many jobs right now that are only virtually, but I have been in communication with the business community. I think many of these people would be ideal at call centers if for whatever reason they don't want to work in an office or clinic. So we want to try to connect as many of them as possible with the job.
Got it. But so I'm clear, without people being contacted directly by the contact tracers, how will H&H ensure that COVID-19 positive individuals have all the resources available to them? I know you mentioned that there's a number that people can call, but how's the outreach going to happen there?
Yeah, the outreach will happen both. These things always have to be multifactorial. You got to do social media, you got to do paid advertisement on bus shelters and subways, and then you have to do clinical outreach. So every positive test still gets reported to the clinician. So for example, on my computer system, I know every time one of my patients is positive, and I'm able to call them and make sure that they get appropriate treatment. So it will become more of a clinical function, which is frankly how we do with other diseases. That's the HIV model, that's the hepatitis model. So because we recognize that COVID is going to be with us, and that's the whole recovery and resilience, that's the whole theme of your committee, is figuring out, okay, well, how do we incorporate these things into our existing system?
And now going into treatments. So what are the antiviral treatments? When will the antiviral treatments first become available? There was a limited supply. What's the current supply level of the COVID-19 treatments currently?
So right now, supply is good. we have both the monoclonal antibody, which requires the infusion, and we have the ability to get people a prescription for the Pfizer drug through the pharmacy. You may have read, and I certainly have concern that at the federal level, they did not pass the bill to continue to fund these drugs. It's my expectation that they will, that this is just a little bit of a federal hiccup. The president had proposed funding for the new COVID plan. I saw the Surgeon General spoke out about the lack of a funding. We are very hopeful that those programs will be funded. I just want to read the three centers that I didn't want to get wrong. 1920 Webster Avenue in Tremont, Bronx, 815 Broadway in Bushwick, Brooklyn, and 3433 Junction Boulevard in Queens. Those are the addresses.
Thank you, Dr. Katz. And how widely available are the treatments, and what else could H&H be doing to ensure that New Yorkers at the highest risk, such as seniors and immigrants, are receiving treatments after testing positive?
Yeah, I mean, that's what we're trying to figure out as the test and trace corpse goes away. You know, what are the better ways? And you may have ideas through your committee of things we haven't thought about. Again, our goal is to try to connect it to an existing structure of how people get their care, whether that's in the hospital or the clinic, so that we are able to have it be sustained even while there's no longer any federal dollars to do it. But we will work with senior centers. Those during this period of wind down, that's what the Corps is currently working on, because we're not currently doing contact tracing. We're using all of the staff to figure out all of the connections, whether it's senior centers, community centers, of how people can best learn about these medications.
Okay. And speaking of federal funding, how will H&H fund and the continuing need for testing in fiscal 2023 without federal funding?
Yeah, that could pose an issue. I mean, to the extent that people have Medicaid or insurance, we would have a source of revenue for that. To the extent that they're uninsured, that would fall to us. It's always true in medicine. There are new tests. We have to make them available. This would have to be a priority. I mean, exactly, we haven't yet gamed out how we would do it if the federal government did not continue to provide, but we will have to do it. I mean, it's not like a question of whether or not we're going to provide. We have a single standard of care, which I'm very proud of. We do the same thing whether you're insured Cadillac or whether you have no insurance. We have testing available. We will have to pay for the testing. I will say that because the city set up a pandemic lab, our costs are low. We are able to do testing at huge volume, and we're able to take advantage of robotic features so that we are able to provide testing at a much lower cost than initially or than any small lab would be able to do.
Got it. And are there any other H&H programs that are currently funded by the federal government with federal dollars, I should say, that will be in jeopardy when federal funding isn't renewed?
Well, the way I like to think about it is the federal funding reimburses for existing services. So anything that is currently provided for COVID that is a medical service is reimbursed. When the state of emergency ends, that will cease to be the case. The question will be, when do they end it, and how much COVID expense is there after the emergency is over? Right, I was just looking today, the numbers. We have 27 COVID patients in the 10 hospitals and 7 in the ICU. You'll remember that at our peak, we had 960 in the ICU and 3,700 patients in the 10 hospitals. So if the number remains this low, then I think we can all say, you know, diseases change and health and hospitals will be able to manage the load. I think the only problem would be if they ended the reimbursement and cases stayed very high, then we would have a problem.
Got it. And this is my last two questions here. It's on contracts. How does H&H evaluate their contracts on an ongoing basis? For example, we've talked about this a little bit in the past, Dr. Katz. How do you evaluate the success of the contracted mobile testing sites? There were noted differences between when we would have an H&H mobile van versus one that was a contracted one, right? We would see that they weren't able to have language translation at these sites. They'd show up whenever they showed up. They wouldn't show up on time. You know, there's a lot of missteps there. You can just tell us, you know, how you guys go about evaluating that. That would be helpful.
Sure. Well, Stuart, like you, I'm a public sector guy, right? I didn't get in this to contract out. Other people are constantly trying to contract out. I'm always trying to bring it back in because I believe when you have a fully unionized public workforce of people getting paid a fair wage and support for those people and culturally appropriate services, people get higher quality of services, and it's well worth paying for that. So I'm always going to be the public sector guy and say, you know, can we bring this in? Obviously, in the pandemic, the demands for testing were so high, and some of the contracts were great, and some of them were not great. And what we started to do, because we knew which ones were great and which ones were not, we started shifting the business. But it's true in the height of, say, Omicron, I was like every contractor I wanted because there was so much demand and we had so many people wanting testing. So, you know, when the problems that you saw arose when you have great demand and not a lot of time to prepare and not a lot of time to evaluate. We're not using those providers anymore that weren't doing a good service. And again, some of the contractors were just great, but others were not. But it's moving away.
Like, is there like a standard evaluation that you
Yes.
do? Like,
yes, and it includes both the number productivity, how many tests did they do, what their turnaround time was, what the satisfaction was from the service.
Okay. And my last question is, what are the current contracts that H&H has with CBOs that are doing outreach and education on COVID-19? And are there any plans for new opportunities for CBOs to contract with H&H?
Well, I think the CBOs have done a great job, especially in some of the harder to reach ethnic communities, new immigrants, where the CBO is the trusted representative for us. So we're maintaining the contracts. We've just extended them an additional period of time, and we're going to work with O&B to be able to, you know, continue as long as possible. I think that's a very valuable service.
Great. Thank you very much, Dr. Katz. Let me turn it over to our committee counsel.
Thank you, Chair. I'm now going to be calling on council members in the order in which they've raised their hand using the Zoom raise hand function. We'll be limiting council member questions and answers to 5 minutes. The Sergeant at Arms will keep a timer and we'll let you know when your time is up. In order, I'll be calling on Majority Whip Brooks Powers, followed by Councilmember Barron, followed by Councilmember Rivera. Majority Whip Brooks Powers, you may begin your questions when you're ready.
Time
Thanks
starts
so
now.
much. Thanks so much, and good morning, everyone. Thank you, Chair Narcisse and Chair Moya, for hosting this hearing, and for the members of the administration who have come to discuss funding initiatives for our city's critical health infrastructure. My constituents in Southeast Queens and the Rockaways are struggling with inequitable distribution of these resources. As we work to craft a budget for the next fiscal year, I want to ensure that funding is established to both expand our city's hospital network and support our existing facilities. I have a few questions for the administration. First, COVID-related federal funding is likely to decrease in the next fiscal year. Is the agency concerned about this possibility? Are there any programs particularly vulnerable to cuts that the agency believes should be prioritized? The pandemic has also strained our hospital staff and resources over the last 2 years. What is the city doing to support its hospital workers? Can Health and Hospitals provide some context on what the agency and its hospitals are doing to recruit and retain staff? What is the city's plan to ensure that, and I know that Chair Narcisse alluded to this, but I'm interested in knowing what is the city's plan to ensure that communities hardest hit by the pandemic have adequate acute care resources, in particular in Far Rockaway. I know that there has been a commitment by the mayor to strengthen our health infrastructure there. We are looking for a hospital with trauma care to help support, one, the lack of access to this acute care service, but also to take away some of the burden that Jamaica Hospital feels from the neighboring districts. And so I like to understand what the city's plan is to address that need in particular, especially when it comes to trauma care in communities that are under-resourced. Far Rockaway was the second deadliest zip code for the COVID-19 pandemic. And so this is a critical issue. It was critical before COVID, but we saw just how vulnerable we were even now. So Dr. Katz, I'd like to hear from you. Thank you.
Thank you so much, Majority Whip. So I wrote them down so I could answer them in order that you asked. With the funding, again, the way that almost all of the funding works from the federal government is it's paying for specific things. So it's paying for additional nursing hours, it's paying for additional tests. To the extent that they stop paying and we have those expenses, then we would have a problem. To the extent that the expenses go down because the number of cases stays low, and again, 27 patients for 10 hospitals, I mean, that's very, very manageable, will be okay. The problematic scenario would be the federal government ends the state of emergency, stops supporting local hospitals, and the number of cases continues to grow. And then we have the expense, but no revenue. I'm hoping that does not happen. I'm encouraged that they have not yet ended the state of emergency, although they have, as we discussed before, said they would no longer support contact tracing. But again, I understand that it doesn't really work very well under Omicron. In terms of the hospitals and I appreciate your highlighting the struggles of our healthcare heroes and the trauma that they live through. Our goal is to provide a psychologist dedicated only to our staff at each of our sites. And the idea would be, of course, it's completely confidential. It's not related to employment. It would be a psychologist who anyone could go and talk to. We already have the Helping Healers Heal, which is a peer-led program. So doctors talking to doctors, nurses talking to nurses, social workers talking to social workers, and cross-discipline as well. But that's peer, that's not professional. We want to have a psychologist who's available at each of the hospitals and would be available to clinic staff as well, who continue to feel trauma or had flashbacks back. And then just to say, while it's not a simple problem to solve access in Far Rockaway, I definitely understand the problem. It's geographically, it is isolated. I think it's also growing. And I think that's one of the things that we need to talk about, is that prior projections were based on the population that was living in the Rockaways, but that population is markedly increasing. You have a number of affordable housing projects growing, and we need to be sure that we are able to meet the needs of those people. You're wise enough to know that it will always be a challenge to provide every intense level of service that people would like in every area because of the specialty issues. So a trauma center, to be a trauma center, has to have neurosurgeons, has to have orthopedists, and that's what makes the challenge. As we were talking about before, primary care, I can always create clinics near to where people live and work. When it comes to hospitals, trauma centers, what we have to figure out together is what's the volume that supports the neurosurgeons, the operating rooms, the anesthesiologists. It may be, again, as we're talking, that's going to change in Far Rockaway based on the growth of populations, and I'm happy to work with you on those issues.
Time
Thank you,
expired.
Dr. Katz, and I would love to work very closely with you on this, especially when you think about not only are we geographically isolated, but nearby also in my district is JFK Airport. If there ever was a serious incident of any large magnitude, we would just not be prepared for that. In the summertime, we often have drownings. This is not to even take into account the shootings that we see in the community. And so it is most critical. I'm going to continue to sound the alarm, but I'm thankful to hear from you that you're willing to work with me to see how we can get this done. And it's definitely needed because Rockaway is booming, to say the least, in terms of the development that's happening. And we can't build anymore in Rockaway without a hospital, as far as I'm concerned. It's just not safe anymore. So we have to do something to address this need.
Understood. Thank you.
Thank you.
Thank you. And now we'll be turning to Councilmember Barron for questions. You can start as soon as the sergeant cues you.
Time starts now.
Thank you very much, Dr. Katz. One of the things that is never addressed is the racism that permeates every institution in New York City, bar none. So we always talk about growth and lack of services because we don't have funds. But in the neediest communities, we don't receive the most resources, not even by way of health and hospitals. And the staff, the Black and Brown, Latinos, Latinx people, do not receive the kind of protection and salaries that they should get, and also housing. You know, in my area, Brookdale is the hospital. It's a volunteer hospital. So we have a, relationship fighting for Brookdale volunteer hospitals. But whether the hospital is a volunteer hospital or a public hospital, when it comes to healthcare delivery services and Black and Brown communities, the racism is a problem. So I want you to address that, and particularly who on your higher echelon, on your higher staff, how diverse is it? How many Blacks, how many Latinos in the higher management position, in the power positions, number one. Number two, the Medicaid redesign program. Come on, doctor, you know that was his cuts. He said savings. Every time they say savings, they're talking about cuts. And the Medicaid reimbursement to our hospitals is just incredibly outrageous when it comes to that. And many of our hospitals are Medicaid dependent. Private insurance in most white communities, affluent communities, 80% of the hospitals are run on private insurance, and our communities is vice versa. So that was a $2.5 billion in the Medicaid cut. So if we can hold those two things. And then the last thing I want to mention, or last two things, is the latest variant You know, I'm really concerned, and this is what a lot of people are concerned with. You tell us to get one shot, we got it. You tell us to get another shot, we got it. Now we need a booster, we got the booster. Now we need a booster to the booster. And you know, people are saying, get your fourth shot. And while we're getting all these shots, and it doesn't stop you from catching it, but it'll stop you from being severely ill. And I understand that. But the pharmaceutical companies are making billions of dollars. So people are saying, wait a minute, are we going to have what they call a variant specific vaccinations for every variant that comes? You know, they're coming up with one now, the BA2 variant that's in Europe and on the East Coast here. So we're talking about a BA2 variant, Omicron variant, you know, variant to the variants and vaccination and boosters and boosters. People are becoming concerned. You know, what's going on here? You know, can't we get a booster that lasts for 2 years or a year or two? And then you get a booster and say, oh, 6 months, you're gonna need another one. And I have had the experience of having COVID, and I was in Brookdale Hospital. I had it real bad, doc. I had you know, double pneumonia in my lungs, 102-degree temperature. You know, my oxidation level was at 80, and they wanted me at 98. And, you know, my blood pressure, all of that. And thank God for prayers and, you know, people, and they treated me well in Brookdale, I must say. I don't even have no long range effects. And I was put in intensive care. And when the doctor came in, he said, you know, you got worse. I said, how much worse can I get? I'm in intensive care. So even while I was in intensive care, I got worse. And he said, but don't worry, you're not going to die. I said, doctor, don't ever mention death in my name in the same breath, because it never crossed my mind. And I'm very fortunate to say I have I'm not out of breath. I could run. I don't have no pain, no short memories, nothing. So, you know, I thank God for that. But I said all of that to say, I'm really concerned about what's going on with all these variants. And are we going to have variant-specific vaccinations for every variant, you know, that comes out, and then a booster to that vaccination? You know, it makes us think under this capitalist system where healthcare is a multi-billion-dollar industry, what's going on? And finally, could you tell people what is the content? What's in the vaccine? Particularly the 2 Pfizer shots. What's in it? I heard different things. Thank you.
Well, thank you. And council member, I want to start by saying God is good because you're with us. And that's a wonderful thing. Just to have you here, that's wonderful. And I'm appreciative to God for that. I want to also mention, just because there is so much misunderstanding about long COVID, one of the fascinating things about long COVID is it's not related to how seriously you get sick. That's one of the puzzles about it. So people are as likely to get long COVID if they have minor or asymptomatic initial cases as if they, like you, had a really serious case. The long COVID is probably something immunologic. It's probably not related to the virus itself. It's related to how your body responded to the virus. So somebody might have responded in a way that they had no symptoms, but they got long COVID anyway. Just, you know, to help us all understand what's going on. So let me start where you started. You know, sir, sadly, we live in a racist culture. I don't think there's any question about that, and the mortality statistics don't lie. Black and brown people in New York City live shorter lives, and that's certainly the most profound way to express that. I do feel proud, you know, you said, you know, leadership, the chief medical officer of Health and Hospitals, Dr. Michelle Allen, African-American, the chief nursing officer is a Haitian-American, Natalia Sineas. The majority of our hospital CEOs are African-American or Latino. You know best the ones in your area, Sheldon McLeod and Greg Solis. So, I mean, when you put all my hospital CEOs together, they don't look like hospital CEOs in a boardroom. They're real people who understand what life was like when they themselves experienced the racism of our society. So I'm happy to provide the numbers, but when I look around my cabinet room, I only think we don't look like, your typical hospital boardroom. And I'm very proud of that. You raised the pharmaceutical company. I thought that's a great point. Nobody's talking about that. They're making huge amounts of money, huge, and not just from the vaccines, right? But the antiviral drugs. So Pfizer has a vaccine and an antiviral drug, and they're getting paid for every single person through the federal government. Nobody is saying, hey, pharmaceutical companies, what are you doing with those profits?
Right.
Why aren't you investing those profits into the communities that have been most affected? We live in a capitalist society, but all of us need to, put pressure on our government because the government's paying the bill.
That's right.
So let's put some pressure on them. The latest variant is scary, as you say. We think it's close enough to Omicron that it should work the same as Omicron, and that people who were exposed to Omicron should be okay. In general, we had a lot of people exposed to Omicron, so I'm not expecting that the variant that is related to Omicron, the one that you mentioned, B2, is going to be a problem, but I agree, we don't know. What's in the vaccine is a molecule of messenger RNA that helps to teach our bodies how to build antibodies. So it's like a messenger signal, and then it goes away. It does not stay in our body. And that's one of the things we like about the RNA vaccines, is that the particle itself goes away, so that you were vaccinated, sir, there should be no RNA in your body at this moment, unless it's your own, but none from the vaccine. But that the vaccine taught your body how to make antibodies. Of course, in your case, your body also made antibodies when you got sick. So you have both. And I just wish you very good health, sir.
Thank you. The other piece of it, is there fats in there, water and fats, fatty acids or whatever, also in the vaccine? Some fats I heard was in it.
There's certainly, every time you always have to have what are called adjuvants.
Adjuvants, yes. That's
the things that make the vaccine work. And right. The two vaccines, Moderna and Pfizer, have different adjuvants.
Right.
But at least at this point, not a whole lot is known about them.
Right. See, that's a little concern about the adjuvants and what side effects, what long range impact it's going to have. And people even thought that the RNA would affect the DNA. So, there's a lot of information out there, whether the RNA is going to affect the DNA and whether the adjuvants would have some kind of side effects, because prior vaccines, it was so bad. Like I heard some of them used to have formaldehyde and all kinds of stuff. And vaccines, when you talk about formaldehyde, you know what I think about that. That's like, when I'm leaving here, you're supposed to hit me with that, not when I'm alive. So.
I'm with you, sir.
Okay,
absolutely,
thank you.
Sir. Thank you so much.
Thank you, Councilmember Barron. Now we're going to turn to Councilmember Rivera for questions. You may begin as soon as the sergeant cues you.
Time starts now.
All right, thank you so much. Thank you to my colleagues and of course the hospital staff for holding this hearing, and to the administration for being here. It's good to see you all. And to the chair for following up on mental health as primary care, especially after our February 25th hearing as to the needs of New Yorkers who are in desperate need of support for mental health care. Of course, to Chair Barron for bringing up Councilmember Barron for bringing up the systemic inequities in our system. As I was, and I will continue to be intentional on mentioning institutional racism as an influence on care in our historically underserved and marginalized communities. So on that topic, I want to pivot to our criminal legal system and ask a few questions on correctional health services. So given the humanitarian crisis at Rikers, we are hearing that people who are incarcerated in the facilities on the island are missing medical appointments at higher rates as the need for medical care is increasing through a public health crisis citywide, hitting the jail system especially hard. How many patients have you seen at Rikers this year? How does this compare with years past? And are there any particular barriers you have been encountering to providing adequate medical care? And my second question, for time purposes, I'm happy to repeat this. How many patients in your care could be deemed to have a chronic illness or need daily medical supervision or constant hospitalization? Are they able to make their appointments? And do you have an idea of the costs associated with this versus being transferred to a hospital facility?
I'm gonna start, and then I'm gonna turn to Dr. Yang for more. I want to again say that Councilmember Rivera, you were so wonderful in the worst times of COVID. I'll never forget, because it was so difficult for all of us, and we were texting and talking late at nights, and you were always interested in what more you could do and how you could help. And I will always remember that, and I'll always appreciate it. I'm going to start in general, and Patsy will give you the numbers. When I came to Health and Hospitals 4.5 years ago, one of the first things I noticed as someone who ran correctional health in San Francisco and in LA, it was better here. And again, nothing to do with me, it was better before I got here. More comprehensive things like providing buprenorphine and to inmates, better sort of mental health services. But it is all dependent on having enough correction officers. So my staff cannot wander through the jail facility providing care. They require escorts if they're going to where the inmates are, and they require protection if the person is coming to the clinic, and especially they require that a correction officer bring the patient to us, to our clinic. And it has been no secret that the last year there have not been enough correction officers. It's a multifocal problem. COVID made it certainly much worse. All we can do as correctional health is constantly prioritize to get the most critically ill patients to us and figure out ways, including Dr. Yang contributed staff to help as correctional officers to get our patients the care they need, but we will always require a sufficient number of staff. So Dr. Yang, I don't know how much of the numbers you have versus what we can provide to Councilmember Rivera following the hearing, but you go forward.
Yeah, thank you, Dr. Katz, and good morning, and thank you for your question, Councilmember Rivera. I think you're aware, correctional health services, we continue both at a system level and at every jail facility level on a constant basis, every tour, every day, to prioritize our patients, and among our prioritized patients, the services that they need. The Department of Correction fully understands and acknowledges the importance of getting patients whom we need to see connected to us. We continue to work with them to make sure that that happens, and that not only do the patients whom we need to see or ask to see us, and we determine that in fact they should be seen, come to us, but that we are able to provide care in an environment that is safe also for our own staff. Certainly, we've spoken. Last summer was a really the nadir into early fall, and we were, I think, collectively relieved to see that when the Department of Correction reopened EMTC, as we had recommended, that really helped relieve some of the pressures that have been building up over the months in the jails, in terms of not only access to care, but just the general conditions of the jails. We continue to work with the department every day. This is a top priority, so that the services that we prioritize are in fact provided. I don't have the specific numbers that you asked for. I can certainly get them to you. I apologize for that. But certainly we have not encountered any difficulty in terms of people who need acute hospitalization getting hospitalized. The relationship that we have with the larger system, Health and Hospitals, really has benefited that. Our relationship at a provider, clinician level, administrative level, within Health and Hospitals, and specifically between Bellevue in particular and Elmhurst, has never been closer. And in fact, I think that's also helped smooth out the Department of Corrections relationships between, in terms of supporting that relationship that we have with the acute facilities. We continue to push ahead, not only prioritizing the services and prioritizing our patients, and doing whatever workarounds that we might need on a case-by-case basis to make sure that care is provided, but really to improve the system. I think last year we were really excited to be able to secure approval for our third site for our pioneering project, our outposted units. We think that will significantly improve access and quality of care for some of our most vulnerable patients, particularly as things change in the jail system environmentally. So we're excited about that. We're proceeding quickly with that. Bellevue is the first to open, and we think that will help, along with all the other changes that are happening as the criminal legal system continues to change.
Time expired.
Madam Chair, if I can just follow up, because I did not get a single answer to my questions. And I just want to ask whether you have any of the numbers. I mean, you work very closely with Health and Hospitals, so you know what it costs to hospitalize a person. So do you have the cost related to that inside the jail system itself? And if not, you do not have the numbers of patients that you see and how those numbers have changed over time. Did you not measure them during the pandemic to have an idea of how that crisis hit you so disproportionately?
The way we are budgeted is to expect whether the daily census in the jail is below 5,000 or close to 6,000 or 4,000. And depending on the complexity of each individual patient in custody is what we will meet. We are staffed to do that. That is not to say that like every other sector in the healthcare system, we have not encountered difficulty in recruiting and retaining individuals, but we cover our staff so that we meet the need of our patients. I apologize. I did note that we are not having a problem hospitalizing any of our patients. If they need acute care, we have worked with them. In fact, the city administration has also helped. The state administration has been very helpful as well in terms of securing beds for people who need them, regardless of what the situation is, either at the state or the city level. We can certainly
Dr. Yang, I think the issue that the council member was asking was two things. First, can we provide our data on the number of people we saw? So I mean that we do have that data.
Right, and you did mention one of the barriers was conditions at the jail. Do you mean the physical conditions or the corrections officers' challenge? And thank you, Madam Chair, for being so gracious with the time.
Ability of the correctional officers to bring patients. And again, I think that we, as Dr. Yang said, we hit the low point this past summer. They've been building up their staff. Things are getting better, but we will provide the exact number of people we have seen. We do have that data. What I was going to say to Dr. Yang, we don't, in terms of costs, no question the costs are higher in the hospital. than they would be at Rikers. But I would say we've always tried to maintain a low threshold to send someone to the hospital. We don't try to keep people at Rikers. Somebody who we might have kept at home, if they had a home, we will bring to the hospital because of our feeling is under the best of circumstances, Rikers is a jail. And so if people don't always have free access to getting help as quickly. So we don't worry about the increased cost. We try to, if somebody looks even a little bit sicker than they should be in the jail, we'll move them. But no question, the cost of hospitals is thousands of dollars a day and way more than it would be at Rikers.
Yeah, thank you, Dr. Katz. Yes, we will get you those numbers specifically. Our access report is on our website, and we can provide you those data directly for your convenience. And certainly, as Dr. Katz said, where we have any question, we will provide that care. Even in the jails, we provide care at a level that in the community wouldn't be required, but that's partly a function of being in custody in the carceral setting. The other issue is that certainly for people who are hospitalized, and I see that my colleague, Mr. Olberg, is on, but that's certainly in hospital during those stays, that is Medicaid reimbursable, and the system does bill for that to help offset the cost of the city for that.
Thank you.
Thank you, Councilmember. And I'm going to turn it back to Chair Narcisse for questions.
Thank you. Since we are on correctional health services, I'm going to continue by asking a few questions. Bear with me. Considering that violence, serious injury, stabbing, and slashing and assaults have rising in the city jails, has correctional health services budgets seen a corresponding increase in its resources? Can CHS give the committee an estimate of its needs? One of the major barriers to people incarcerated receiving care is the staff shortage of correctional staff who accompany the individual to CHS. Is there a way to bring medical services to the patients?
So Chair, the money would best be spent on having enough correction officers. We are staffed to care for the inmates. The problem is that we cannot care for the inmates if they're not brought to us. We are happy to go into the housing units, but obviously our staff can only do that with escorts. And so the challenge sometimes, especially in the large group residences at Rikers, is that there's no privacy. So you can't really do an exam often, especially how accidents occurred, how trauma because of gang issues. People may be very reluctant to admit what happened to them. So the answer has to be enough correctional officers to bring us the patients so that we can see them in an area that is safe for them, safe for us, and provides confidential space. But we have enough, our staffing is enough to see the patients. It's just getting them to us that has been the challenge, especially during the summer.
Yeah, sorry, Dr. Katz, thank you for that. And I would just additionally note that the reason why we're so part of the reason why we're so excited about the units that we're going to be building that we are building at Bellevue and at Woodhull and at NCB is that as we have shown in the jails, our therapeutic units are where some of our staff, in partnership with the Department of Corrections staff, are embedded in those units, so that we are in fact in the housing areas where people live, and so that access is there and the ability to work with our patients in terms of compliance and getting medication and treatment is much easier. We are in fact in those units with them.
So in other words, you coordinate different type from the discharge from the jail to the housing. I'm kind of.
Sorry, yes, that the units that I'm talking about are while people are still in custody. So they are in special housing units that are more therapeutic because our staff are there. They are at the physical plant and the operations, and the staff who are there, which is whether it's Department of Correction staff or my staff, work together to have the care provided on the units themselves. Really speaking to what Dr. Katz had noted earlier, most of the housing areas do not offer the kind of environment and the privacy and really the facility to do that. So we have some units like this in the jails now, but what we're really doing is putting some out into the 3 hospital facilities and certainly in the new jails.
Okay. Can you provide an update on all the options available for discharge planning for a person exiting the detention? If a person has both a physical and a mental health condition, how do the 2 different type of care coordinate?
We have probably one of the more robust jail discharge planning efforts. We start day 1 when you come in, when you're admitted to the system. We begin to work with you in terms of what your resources are and what your resource needs may be, and that may include making sure, for example, very importantly, having access to health insurance or Medicaid on the day you leave. Depending on your individual need, we will work with community partners and agencies either to connect you to care and services if you don't already have a provider. That is, again, a great advantage of being part of Health and Hospitals is that we have the relationships there where we can not only make a referral, but actually make you appointments and do a warm handover from discharge to a provider. One of the things that we're very pleased with has been our point of reentry and transition service practices, which is clinics basically that we opened at Bellevue and at Kings County a couple of years ago, where the same providers, the same doctors who work in the jails and see you and provide care to you in the jails will also see you on the outside after release. So you can see the same doctor that you saw. And our doctors work side by side with the hospital doctors so that we can help transition literally warmly among the providers as you reenter and stay in the community. And so that, Bellevue and Kings become your regular provider. And we have helped through that transition process. So it depends on what your mental health needs are on discharge. We also will assist in completing applications for housing, for example, and we work with the Department of Social Services for that. So we will provide as much as we can, as much as you need in terms of planning and resource connections before you leave jail.
But I personally see a lot of kind of acute mental health crisis going around us, especially it has to do with people that just come out of jail. So I was wondering if there's any follow-up. What is the percentage of the discharge inmate that end up in the actually direct partnership with whether it's the community health organization or the hospital? Because I see so many on the street, and you can tell that they have issue. And I used to do a reentry program, by the way, and it's not easy.
Yeah, let me intervene here and just say that we would love to work with you, Chair, around the fact that the system has, especially for homeless mentally ill, nothing between hospitalization and outpatient care. And that this is a huge hole in the mental health system, especially for people with recent incarcerations. And I've been working with other city leaders, including the mayor's staff, on trying to address, we need a place for especially homeless or unstably housed people with mental illness who can go and get appropriate treatment, food, housing. It can't be a high barrier. It can't be multiple forms. Ultimately, these people need supportive housing, but that takes time. both to create the units and to get people through the leasing process. And so we want to figure out a place and enough supply, because otherwise, as you're pointing out, there is an unhelpful cycle between Rikers, psychiatric emergency room, inpatient psychiatric services, and the street. And if we want to interrupt that, then we have to find something that works for people who are not so acute as to need an acute care hospital bed, but who are homeless and cannot possibly maintain their mental health while living on the street. I do not believe that someone with serious mental illness can live on the street and maintain mental health. I just don't see that as possible. And yet that's what we currently expect. I mean, that's the system's fault. And ironically, it perfectly parallels insurance. Insurance pays for acute psychiatric hospitalization and outpatient, and it pays for nothing in between. But homeless people have to have something in between. And I think if we can together figure out how to do this, we will make a huge difference for people from a humanitarian point of view, and also how the subways and how the streets look.
Good at all to me. It does not look good. And as society, I think we're failing that part. The Adam administration has spoken about wanting to increase the number of inpatient psychiatric beds. I've been hearing that, right, in New York City, but has cited that the state needs to provide more funding and increase the number of beds. Is there a reason that the city cannot use city funding to increase the number of beds?
At the moment, our issue is workforce, an issue close to your heart. So we could open more beds even with the existing rates if we had more mental health staff. COVID has really disrupted things. Fewer people want to work in acute psychiatric hospitals. People are doing therapy by Zoom from their homes. It's a different kind of work. And so without a sufficient number of psychiatrists, we cannot open up additional mental health beds. But our behavioral health chief is working hard. We have a group of new psychiatrists who will be coming when this year of residency ends. We're working with OMB and OLR to make our salaries competitive. But right now, it's all about workforce. And we're also, you as a nurse will be interested, we think that one of the ways to help is psychiatric nurse practitioners. That we think psychiatric nurse practitioners can do much of the work that would enable us to open up more psychiatric beds. And so we want to engage in a training program that would be specific to psychiatric work. We think that nurses do super well at that.
Thank you. How many inpatient psychiatric beds do you have currently now? And what is the occupancy?
The staff beds are 100% full. John, do you have the number?
Yeah, we run 1,000 inpatient psych beds, and we're shooting to bring back online about 220.
Thank you. You are superb on that. Dr. Katz, I don't know. I have so many questions because now I have to go to Be Heard because I still have to go with psych, right? The Be Heard pilot program was launched in November 2020 in 2 precincts, right? And the Adam administration's sober safety plan expand the pilot program to 11 precincts. How much additional funding will be needed to reach the additional precincts?
Let me ask John if he can provide us that dollar amount. While he's looking for it, I'll say what a great program, right? When you people in mental health crisis don't necessarily respond to police the way you or I respond to police. So when somebody calls out and says, stop, stop, what they may hear is run, run.
Run.
And so you need people who understand and who can de-escalate a situation. John, do you know the number?
Yeah, I'll have to get back. We're in the process of working on that, based on what we're seeing as the model that we've deployed, and we do want to grow it, and we're working with OMB on those numbers. So if you could just give me a couple of days, I can provide that.
No problem. How can the expansion of this program be expedited? And what is the H&H doing to recruit social workers and EMS workers? Because we're talking about that. We have a shortage. H&H, street health outreach and wellness vans. I want them to be on the street, guys. We have to get those guys out of the street. And thank you, Dr. Katz, for the idea of getting a nurse practitioner involved, because we know they care and they can get the job done. Both the fiscal 2022 adopted plan and the fiscal 22 November plan include additional funding for H&H street health outreach and wellness show vans. The mayor's subway safety plan will deploy an additional 3 vans for a total of 9 vans active citywide. What will the total budget be for show? And how many vans are currently deployed? What is the head count? Can a breakdown of what the position titles are for each van?
John, I don't know, some of those questions I'm sure you don't yet have an answer for. There are currently 6 vans working, and we're planning on bringing on 3 new vans. I also, just to show you that we care about getting you numbers, the answer to your earlier question, Chair, is there are 57 total Gotham sites. That includes both the larger sites that you know well, like East New York,
yes.
57, but it also includes, school-based clinics and much smaller sites. But the total number is 57. John, which numbers can we provide here?
Yes, on show, we started the program, with T2, and now we're transferring it, as we're phasing out of COVID, we're transferring those costs into H&H. And the numbers that we have is roughly about $13 million in expenses, and there's revenue as an offset. We can bill insurance companies. We'll have to work on this because this will be a little unique. It'll be a revenue offset of about $3 million. So $10 million is our rough estimate. It's an excellent program. And I think one of the messages I think that Dr. Katz has been delivering here is that we need to be more flexible with the reimbursement dollars so we can be flexible in terms of where we provide those services. So we're working with our insurance partners on those sorts of models. But $10 million net is our estimate.
You have it?
I think we said 13 million.
He said 13 million, yeah. Yes, I want to make sure I get the number. I heard the number.
Yeah.
For mental health, we know it's a problem. The fiscal 2023 preliminary plan includes 1.7 million for the mental health continuum, which is an investment in mental health in schools. Can you provide details of H&H contribution to this program? Is this an extension to the support of H&H already provides to DOE? Is H&H fully staffed up for this program? Does H&H know the age range that the mental health continuum will support? Will our youngest New Yorkers have access to mental health screenings?
Well, I'll just say on the access, yes. I mean, the youngest New Yorkers, there is a huge crisis right now in childhood mental health, which Chair, our children took the pandemic very hard because of the closure of school and the interruption of normal routines, loss of very important developmental features. Video learning was better than no learning, but was not at all like being in class. We're seeing a large number of children who are very much disturbed by the recent events, and we are determined to care for them and see them. We're struggling, again, more with workforce than with dollars. But if the dollars would ultimately pay, and Chair Moya had mentioned this as well, salaries that are correct, we would be better able to deal with this issue. John, what can you tell us about actual dollars?
Yeah, I can get the specifics on the program in terms of the dollars that we have. I will say that we always welcome more in this area as it relates to children and psychiatric services. But we'll get the specifics. I think the other area is we're trying to reopen and expand inpatient psych beds for children. So that's part of our plan for the coming year. But we'll get you the details on the connection back to the Department of Education. Some of the money's embedded in their budget too. So I have some work that I need to do there.
Helping Healers Heal, right? Our frontline workers were hardest hit by the devastation. I think you mentioned that briefly, that on the pandemic and continue to experience trauma. I feel like you had answered some or part of this. We spoke about it. Do you have the set of address the mental health needs of your staff? Actually, I'm hearing that before you said that it's some of them are the doctors and the nurses, they're healing each other, they're helping each other out, if I'm correct.
Right. Yeah, so the way I think about it is there's support that all of us can get from peers, right?
Okay.
For knowing that you lived through a difficult thing. Sometimes peers can be the most effective. But what if you have post-traumatic stress syndrome? That goes beyond what you would expect a peer to be able to help you with. That's a mental illness that requires specific kinds of treatment. And that's why we want to embed a psychologist at all of our hospitals. Of course, all our staff have city health insurance and can reach out into the private sector, but we're not convinced that people will do that. People may feel a sense of stigma, and that we think having somebody who is local, who's well-known, who deals only with these issues. You know, healthcare workers, you know this from your work, we're taught to be tough. We're the ones that are supposed to provide support to other people. And so there is a certain stigma at even asking for help. And that's why we thought doing something beyond peers that was professional, but yet not something that required someone to actually make an appointment with a psychiatrist with their city health insurance. We wanted something in the middle.
Okay. Have H&H staff been able to successfully take the mental health days they were provided? Has H&H collected any data on this?
We're currently encouraging everybody to take their vacation days. During the pandemic, many people took no vacation days, no days off. People knew that if they were off, life would be hard for their colleagues. We have an incredibly responsible, caring workforce. So now what we're telling people is this is a good time. We want you to take off. Taking time off is important. I sent out a message urging people to take time off to refresh themselves. And we're going to continue to advise people to do so.
Okay. Omicron surge resources we're talking about. In January 2022, the Adam administration announced $111 million investment to immediately expand both DOHMH and H&H staffing needs and to reinforce healthcare front lines. How much of the $111 million did H&H receive? How was the funding utilized?
So I'll start with how it was utilized, and John can say if it was fully spent. We knew in Omicron that we needed to hire a large number of registry nurses because so many of our own nurses were sick and couldn't work. And yet we were overrun with patients needing care. Also, the nurse registry groups were charging quite outrageous amounts. And I think some of those, just like with the pharmaceutical companies, I think, you know, somebody needs to look at how, you know, capitalism has resulted in people profiting from other people's pain. But I don't think the nurses were getting those rates. I think the agencies were getting those rates. But nonetheless, we needed to pay them because we couldn't have no nurses, and we hope that FEMA will ultimately reimburse the city.
I'm kind of in agreement with you on that one. I don't think it's the nurses that are getting the money. It was they probably get some, but it was the agency mostly playing that. Mental health in domestic violence, we talk in shelters. Can you provide details on how H&H will support the mental health services in domestic violence shelters program?
I think on that, I will have to get back to you. We love our colleagues in our sister agency of Department of Homeless Services. We work all the time. I was working with them. They're great people just over the weekend on the subway issues. We are always available for consultation, but most shelters have a provider, and the provider, a CBO provider, usually provides the mental health services. The services we provide are when shelters send us patients who need more than can be provided within the shelter.
Thank you. Staffing, we talk about staffing in many ways. The staff shortage that exists isn't completely due to burnout from COVID-19. We know that. The need for more incentive recruitment was needed long before the pandemic. What programs does H&H have to recruit and train young people to build up staffing in the future?
Yeah, I think this is a key issue. And I think we have to start by providing tuition assistance and perhaps even stipends to people who are going into careers like nursing or medicine, and then they can repay it to us by working for us a set of years. But when I think about, who wants to become a nurse, as you know, becoming a nurse is hard work. That's a lot of years of study. And what if your family requires that you make money? Not everybody, even if tuition is free, not everybody has the luxury to not earn a living while you're going to nursing school, while you're going to medical school. And so I think we need to, if we put our money only into higher wages, it doesn't build the supply, and we will always be outbid by other private systems. If instead, though, we put our money into paying for people to go to nursing school or medical school and provide them a stipend so that they can live, and then they're required to work for us for X years in exchange for that, then we've actually grown the workforce. We will pull in naturally a more diverse set of people because we will have provided an economic opportunity. And those people will stay with us. And once, like with you, once you've seen us and you recognize we're not always the easiest place to work, but no one's got a better mission than us. And so I think people will stick with us.
Like I always say, nursing is a calling. So if you have a lot of folks that can be having that calling, but you have to reach out to them. And I appreciate the plan you just lay out. If we encourage, we give incentive in the front, and then encourage those young folks, because like we said, not everybody have the luxury. You probably have a family, you probably already have a child, you probably live in a shelter. You have some great minded shelters. So we have to offer this opportunity, and that's how we're gonna meet the inequity we're talking about. We have to have equity, and that's how you uplift communities of color, Black and brown communities. There's a lot of young folks that would love to do things, love to go to college, but they don't have the opportunity. So thank you for that. What programs exist to incentivize a new nurse to work at H&H over a private hospital? I know I had $4,000. That's how I ended up in the Elmhurst Hospital after nursing school. So what are you doing now? We know 4,000 is not enough.
Yeah. Well, and again, you'll appreciate this because of your own experiences. Our problem is not hiring. Our problem is retaining. And the reason is that we take new nurses. The private systems rely on us to train nurses. And then when the nurse has 2 or 3 years experience, they offer them a job at a markedly higher rate after we've trained them. So they work at a place like Elmhurst, they become incredibly competent nurses, and then at year 2, year 3, they're offered, a much better paying job. So besides the effort to grow the workforce, our effort has to be in putting in additional retention bonuses. You get so much for staying 5 years, so much for staying 8 years. If you get beyond 10, probably the city pension begins to be a way to stay in, because you then are, gaining a pension, which most private systems don't have. But 25-year-olds are not interested in pension. It's not when you tell them, oh, well, we're the city, we have a pension, they look at you like you've grown, 2 horns. Why would I be interested in a pension? They want to know how much money is in their pocket today. So you got to put the money in the pocket. Again, we can hire people because we hire new nurses, and we have to retain them at least until about year 10. And then I think we might be able to rely on the city pension to keep people in our system. Also, our wages go up as you stay more years.
I'm in agreement with you. I did not invest in pension. I did not want to hear it. I want to see where's the money. I've been there when I got finished nursing school, all of us were looking to see where we can make the most money. That's how young might think. So thank you. What is the salary that H&H has to compete with for a full trained nurse?
John, do you have those figures?
Yeah, I mean, it varies by the type of nurse and the length of their training. But 75 to 95 could go 100, but we can get you the specifics of the schedule.
Okay. Can H&H provide a breakdown of the union employees by representative and entity? Example, DC 37, CWA 1180, PSC, etc.
Yes, that's data we have available. We'll provide it.
Thank you. My office received information that H&H has plans to outsource payroll responsibilities and will be eliminating clerical support staff. Has H&H contracted the services of payroll out? To whom, for how much, and how long? How was the contracting service determined? What is the current head count of those doing payroll services at H&H of full-time employees? It has come to my attention that there are over 26,000 errors regarding payroll at H&H. Can you give me some insight into this problem?
Sure, I can start and John can fill in. First, just to be clear, we're not going to lay off anyone. We need the people who are currently doing payroll to do other jobs. And so we're not planning on laying off anyone. About 10, 15 years ago, Health and Hospitals created a payroll system. That payroll system was inadequate for the needs of Health and Hospitals. Health and Hospitals employs 40,000 people, and as you'll remember yourself from hospital nursing, there is a different rate for nursing if you're working on a weekend and if you work a holiday. If you work a holiday after a weekend, if you work more than 40 hours in a particular week, our payroll system was never designed to deal with that. And for that reason, we have a large number of errors. No, they're not intended errors. It's just that the circumstances are too complicated, and it's got worse the last couple of years because appropriately we would turn on various COVID incentives or bonuses for a period of time, and then they would go off. And so the system really could not keep track of that. So we have gone out to bid. There is a contract before my board, the Board of Health and Hospitals, will hear it in committee tomorrow, and at the board the last week in March. We went out to all bidders. The winning bidder was a modern system that's able to do the level of payroll that we need. And I think this will eliminate the errors. And meanwhile, we're going backwards to figure out in each case, it's public money. And so we're very careful. Someone might come and say, we have a lot of times a doctor or nurse will say, I worked 4 shifts and I got paid only for 3. You owe me 1 shift. And I'll think to myself, I'm sure you're correct, but I can't just pay you because of that. This is public money. So now let's figure out which shift it was that you didn't get paid for. And that shift may be on one side of a payroll week or a different side, and how much you get may depend on how many hours you worked in that payroll. So each one has to be individually reviewed by John's staff and has to be subject to audit and has to be correct. And so it takes us a very long time with our current system to correct this. We believe that all of this will go away with the new system.
And how many, what is the current head count of those doing payroll?
It's about 100 employees today. We met with them as we were developing this idea. As Dr. Katz said, the payroll system is a vulnerability for us, and we need to move swiftly to the new system. We've met with the payroll. I met with them about 6 months ago, and we assured them all that they would, continue to have a job with health and hospitals. And we've been working actively with each and every one of them to find new opportunities within health and hospitals. I mean, it's a great thing about health and hospitals. We're a big organization and there's plenty of work to do. And, our hope is that by the time we launch with the new system, each one of those 100 people will be placed in a job that they feel like they can be useful at and be productive.
So 100 in total?
100, about 100, yes.
About 100 in total. Okay, so the company that you bring is not taking any of those folks that was in the payroll department, or they're gonna come with the new layout folks to do it, total contract?
Their new system won't require the manual work that Dr. Katz just mentioned, right? It will be much more streamlined, much more modern. The big healthcare systems and other systems in the city use the same system. So we don't think, and there may be some opportunities, within payroll, but not many. And again, what we want to do is make sure each and every one of them get placed someplace else within the organization.
Best to think of the new payroll system as a computer system. It's really, what you're really paying for is software. And that's what we don't have. We have a manual system that can't possibly cope with the level of complexity we have at health and hospitals.
Has a union involved to?
Yeah, I talked to Henry Garrido at the very beginning and assured him that nobody would lose their job. And he recognizes that his own members are upset that their paychecks are not correct and that it takes so much effort to correct them. So he was very supportive with my assurance that we were not going to, let go of anyone.
All right, thank you so much. Appreciate that. And for those that want to retire, like let's say they are the kind of the close to it, would a package offered to them? Because if they don't want to go to, because I understand, because I work in the hospital. Let's say you change and you're making the transition, but they've been there, they've been doing this for many years. Would they be offered a package if they want to exit?
You mean the payroll people?
Yes.
I think our feeling at this point is that the kind of work they do, we have all over health and hospitals. So it's not, it isn't, we have so much finance work to do because of the size that, it's not as if we're going to be saying, now you're a cafeteria worker. Right.
I just have to advocate, that's my thing. That's my nature.
The work, we have a lot of good work that needs to be done that fits the same things people are doing.
Okay. Thank you. You're so fast, Dr. Katz. I love that. Because you take one person from payroll, you send them to clean the bathroom or to do somewhere else. Nothing wrong because they're not used to it. They're not used to that particular area and they're getting of age. They've been doing it for many years. So you have to accommodate them somehow, some way.
Understood.
Because we are the one that decided this is not something you're going to
That is correct. If we were changing what people were doing, we would do that.
Thank you. I appreciate that. Now I'm going to turn it to Habani. Thank you so much, Dr. Katz and the whole team.
Thank you.
Dr. Olberg, thank you so much. Appreciate your time. So I'm turning it back to Albani. Thank you.
Thank you, Chair. I just want to confirm if there are any other council member questions, folks can raise their hand using the Zoom raise hand function now.
Okay, we're not seeing any other questions. I'd like to thank this panel for their testimony. Thank you so much, Dr. Katz. And now we'll be moving on to public testimony. All public testimony will be limited to 2 minutes. After I call your name, please wait a brief moment for the Sergeant at Arms to announce that you may begin before starting your testimony. Please note that panelists will be able to register for this hearing until the hearing is closed. The first public panel in order of speaking is Cynthia Tucker, followed by Mia Soto, followed by Judith Cutchin, followed by Amy Lynn. Cynthia Tucker, you may begin as soon as the sergeant cues you.
Time starts now.
Yes, good afternoon, Councilor Woman Nanasia and the council members. I just want to say my name is Cynthia Tucker, the Clerk of Social and Payroll, right now at 50 Water Street. My understanding that Dr. Cass said that there would be no services uncut, but if you're gonna outsource our payroll department, that means you're taking away the whole payroll department, and you do have qualified people in here that will work. My understanding that there will be no longer any health and hospital workers working with this corporation, which is now that it is outsourcing us. You only have one hospital, and that's Jacoby Hospital where the payroll is at. The cuts of the payroll is not good because we are workers who know how to do the work, know how to get nursing and staffing paid. We would like to know that at some point, how can we as members of the health and hospital won't be privatized because the unit that you have coming in, UKG, as you're going to sign on March the 31st, is private. And you're outsourcing the hospitals with privatizing us, and we are union people, so that's union busting. And we do need the help from the committee to hear that the monies that in the hospital and there's extra funds that's being translated to the members who are not working here, who are in administrative titles, who are getting salary increases, and the money is much more. But you have thousands of $billions going out that you have oversighted. We pay more people out of work that's not working, who's been gone, and it's over so many monies being translated out of the system. So it's unfair that these people are getting overpaid, and we know that. So I'd like you to be able to address that because we are all union workers. It's over.
Thank you for your testimony. I'd like to now welcome Mia Soto to testify. You may begin as soon as the sergeant cues you.
Time starts now.
Hello, good afternoon. My name is Mia Soto. I'm the community health organizer of the Health Justice Program, the New York Lawyers for the Public Interest, and NILPA is privileged to be part of the City Council's funding, and we really appreciate that support. And I'm here today to really thank and ask the council to continue their support for new funding for the organizations and the partners in our New York City area that provide life-saving support and services for all immigrants and all New Yorkers, regardless of their immigration status. And your funding really supports NILPA's Health Justice Program to continue to fight for racial equity and immigrant justice, particularly through healthcare advocacy, including our work addressing the human rights crisis and immigration detention, and really advocating for healthcare for all New Yorkers. For example, your support has really led to increased enrollment by eligible immigrants in state-funded Medicaid. And the improved access to Medicaid has had really life-changing and often life-saving effects on the lives of our clients. For example, we had a client, Christina, a 37-year-old undocumented Latinx woman living in New York City who needed an urgent medical care. her kidneys were actually failing and she needed a transplant. And despite being eligible for Medicaid, she was actually informed by a local hospital that she did not have, because she did not have a social security number, she was not eligible to receive a transplant. So she turned to NOPI for help. And we were able to secure this opportunity for a transplant for our client. And luckily today she has a new kidney. So we're really thankful for that and for all your support. Final remarks is that we thank you, Chairperson Ortiz and the committee, for giving us the opportunity to present testimony today, and for the tremendous assistance to continue our work supporting our community members, especially those most vulnerable during this pandemic that continues and still harms and affects all of us today. And we continue to ask for renewed funding for the year 2023 for both our work and for our partners citywide. And we look forward to continuing our work to improve immigrant New Yorkers' access to healthcare. Thank you.
Thank you so much for your testimony. I'd like to now welcome Judith Cutchin to testify. You may begin as soon as the sergeant cues you.
Time starts now.
Hello, my name is Judith Cutchin. I am the first vice president of the New York State Nurses Association, and I'm also the Health and Hospitals Executive Council president and mayoral agencies, representing more than 9,000 public sector nurses. I am also employed at Woodhull Hospital for the last 30 years. I want to thank the chair and the other members for allowing me to provide testimony today. The health and hospital system plays a big role in providing care to New Yorkers. It is the biggest hospital system in the city with about 1 in 5 beds, but it plays an even bigger role in providing key services that the private hospitals try to avoid. It accounts for half of the level 1 trauma, half of the psych bed capacity, and has the highest levels of Medicaid and uninsured patients. H&H played a lead role in responding to COVID by caring for very sick patients under tough conditions at Elmhurst Hospital and other H&H facilities, and in providing testing, tracing, and vaccines to New Yorkers. We also provide care to communities of color and low-income people that many privates do not. We are pleased that the new mayor understands the importance of H&H and that the budget provides $717 million in operating support and does not include us in the planned workforce reductions. We are concerned that the amount of funding that the budget is not enough to address the important problems of healthcare inequities and growing our nursing and direct care force. First, we believe there's a 2-tier hospital system in New York. The big academic medical centers make a lot of money by avoiding the poorly compensated Medicaid service that H&H provides. They cater to the wealthier patients with good insurance and leave communities of color and uninsured to be cared for by H&H. This makes the healthcare inequity worse because the safety net hospitals like H&H have less money to provide care for our communities. If we are going to fix inequity in healthcare, we have to provide more support to H&H. Second, H&H is facing a growing staffing crisis. We have lost a lot of nurses and we're having trouble retaining and replacing them. Our pay is more than $10,000 less than in the private sector. We also have worse tier 6 pension for our retirees. Our collective bargaining agreement and new state staffing law require H&H to hire more nurses and improve staffing. This is important to improve quality of care and respond to worsening healthcare inequities. Unless we close the salary gap and improve working conditions for nurses and other workers, H&H will not be able to meet the needs of our communities. If we're going to fix racial inequity and healthcare inequity and properly staff our hospitals, the city will need to increase its support for health and hospitals. Thank you for allowing me to speak.
Thank you so much for your testimony. Next, I'd like to welcome Amy Lynn. After Amy, we'll hear from Manny Patriak. Amy Lynn, you may begin as soon as the sergeant cues you.
Time starts now.
Good afternoon. My name is Amy Lynn, and I am the Health Policy Fellow at CACF, the Coalition for Asian American Children and Families. Thank you very much to Chair Narcisse for holding this hearing and providing this opportunity to testify. Founded in 1986, CACF is the nation's only Pan-Asian children and families advocacy organization and leads the fight for improved and equitable policies, systems, funding, and services to support those in need. In the summer of 2021, we conducted a rapid needs assessment in collaboration with the NYU Center for the Study of Asian American Health and the Chinese American Planning Council. We surveyed over 1,000 adults of Asian, Hispanic, Latinx, or Arab descent living in the metropolitan New York area to assess the current and ongoing needs of the community during the COVID-19 pandemic. This report highlights the disproportionate impact that the COVID-19 pandemic has had on the New York Asian American community. Our survey found that 75% of participants reported having received at least one dose of the vaccine, but there were notable differences by subgroup. Specifically, Bangladeshi and Nepali adults reported having the lowest vaccination rates compared to other Asian subgroups. However, they had very high COVID-19 vaccination acceptance. Respondents said that they were somewhat or very likely to get the COVID-19 vaccine. In other words, the lower uptake of vaccines among Bangladeshi and Nepali adults in the New York City area is likely not due to any vaccine hesitancy, but rather a lack of clear access to the COVID-19 vaccine. Bangladeshi and Nepali adults should be priority populations in COVID-19 vaccination efforts spearheaded by H&H. Moreover, 27% of Asian American respondents indicated that they felt like they did not have regular access to timely, accurate information during the COVID-19 pandemic in their language. Being unable to access vital COVID-19 information or health services can be a threat to one's livelihood, so ensuring language access in public hospitals for all New Yorkers must be prioritized. Because a new wave of COVID-19 may impact New York City soon, and we know that API communities and immigrant communities will be disproportionately impacted, our major recommendations are as follows: improving COVID-19 vaccination language access in public hospitals, expanding language access and services for COVID-19 outreach, testing, and vaccination efforts through providing critical funding to culturally responsive and language accessible community-based social services working on the ground to reach New Yorkers who are most vulnerable. This is in alignment with the Communities Driving Recovery asks, passing Intro 0069-2022 to establish an Office of the Patient Advocate and ensuring its implementation via robust funding, and increasing subsidies for H&H and public hospitals. Thank you so much for your time, and really looking forward to future collaboration.
Thank you so much for your testimony. I'd like to now welcome Manny Patrick to testify. You may begin as soon as the sergeant cues you.
Time starts now.
Let me just turn this other meeting up. Thank you, everyone. It's really an honor to be here. Thank you for inviting us to testify at this hearing on these important issues. I know you're covering a lot of issues around the future of the city and healthcare. We want to focus today on the high cost of hospitals. But before I get into it, just a quick introduction. I'm Manny Pastriche. I'm the Secretary Treasurer of Local 32BJ. As many of you know, we're the largest property service union and represent frontline workers, cleaners, residential porters, doormen, security officers, and window cleaners and airport workers here in the city. Our members have kept New York City running no matter what comes through the pandemic and everything before that. The pandemic, but really everyday life, healthcare is central to what our union does for our members, and it's something that is part of our core mission. We're testifying today because the high cost of healthcare, in particular the high cost of hospitals in New York City, is jeopardizing the ability for us to continue to provide high quality healthcare, and it's something we hope this committee and the City Council will take under consideration. The problem our members are facing on high healthcare costs is not unique to them. It's something that is hurting not New Yorkers as a whole. And given the short period of time, I'm just going to focus on what we think is the key issue. We think that the city, along with other buyers like unions, need to come together to figure out how to bring down the high cost of high hospital prices. If you look at the cost of hospital prices in the city, we and the city as a purchaser for employees are paying roughly 300 or higher percent of the cost of Medicare to get the services that we need. We can give you many, many examples of where us, and again, we assume the city, is paying 2, 3, 4, 5 times the amount for common procedures like colonoscopies, knee and hip replacements than what the average is for Medicare. We don't think as buyers, the city or us are ever going to get Medicare, but that high cost is unsustainable. So again, I know you have a busy time and I can see my time is short with a minute, but we just ask for, as we move forward, that this committee and City Council as a whole take under consideration ways that we can work together to bring down the cost, because the more we bring down the cost, the more services are available, the more money is available to provide more teachers, to provide more trash collection, to provide more police officers, and the kinds of things that the city needs. So we have submitted our written testimony. We thank a number of, I see, city council members who've already been involved in this issue, and we will look forward to working more with this committee and the entire city council as we go forward.
Thank you so much for your testimony. This concludes this public panel's testimony, so I'm going to turn it to Chair Narcisse for any questions.
Thank you. I mean, I hear you, Patrick from 32BJ. I hear you. I hear Miss Mia Soto, Emily Lynn. You have valid, and some of you just asking for support, which we're supposed to give because that's what we live in the city. Our healthcare is very important, and I'm here and I'm committed as a nurse for over 3 decades, work in the hospital and understand, even though I was not in the business of hospital, but I could understand because guess what? I used to have contract with a hospital. I used to have a DME, durable medical equipment. So it is important for our health. It's a priority for me. I'm very committed to this, and I'm looking forward to not only decrease the cost, because as you can see, so many questions that I ask around the waste and what can we do better. Of course, in the city, we're paying much more than our counterpart in other cities, so we need to do much better. So thank you, Dr. Katz. I'm gonna go around because I appreciate every one of you. I would like to thank all of you to participate in this very important preliminary budget hearing this morning. It is important. Hospitals provide healthcare. We know that without our health, we're nothing. And without good health, we are nothing. And we are matters. Thank you, Dr. Katz again, Dr. Patsy Yang, John Alberg, for your testimony and staying to hear the advocates. Thank you to my council colleagues. I appreciate you for being here. Thank you, all the advocates. I'm talking about Cynthia Tucker. We look forward to following up on payroll issues with you. Mia Soto, Judith Senchen, Emmy Lynn, and of course, Mr. Manning. Thank you. 32BJ, you know I got you. I will work closely. I'm a unionized person, and I appreciate the work you've been doing. I'm looking forward to working with you. And thank you to my staff, my Chief of Staff, Sai Joseph, my Deputy Chief of Staff, Frank Shea. Thanks to Albany. You're the best. And Lauren, you are all the team. You are awesome. Thank you for your work, for being an amazing committee. And the Sergeant at Arms, for keeping us moving. I appreciate you, Briando. I appreciate you, Zarowski, and I cannot say anymore. I appreciate you, Sergeant Perez, Stephanie, Ruth. Thank you. Thank you, everyone, for keeping up, because our health is very, very important, and very important to me as a nurse for 3 decades. I'm looking forward to make this city a place to live, work, and enjoy. Thank you so much.
Thank you, Chair. Before we close out the hearing, I just want to quickly ask if we had inadvertently missed anyone that is registered to testify today. You can please use the Zoom raise hand function, and we will call on you in the order in which your hand is raised. Okay, not seeing any hands, Chair. You can close out the hearing.
All right. So everyone, happy to see you. Have a wonderful time and take care. So I'm signing out.